today's video, we will be discussing the causes and mechanisms behind rhabdomyolysis, which I'll probably call rhabdo moving forward. And we're going to talk about causes that differ from the cause presented in this case, so you get a broader perspective of rhabdo. We'll also spend some time discussing complications of rhabdo and some pharmacologic agents that have been associated with this particular condition. So to start off, the causes of rhabdo can be grouped into physical and non-physical causes. The physical ones being trauma and compression, prolonged immobilization, extreme exertion, seizures, ischemia, and extreme body temperature changes. So the non-physical are drugs and toxins, some infections, electrolyte imbalances, and metabolic and genetic disorders, like with our IQ case patient with McArdle's disease. Though there is a lot of heterogeneity in rhabdo causes, there is one commonality, in that they all deplete myocytes of ATP. So this can be from a crush injury preventing blood flow, so there's no oxygen delivered to be used to generate this ATP, or it could be from prolonged seizures and continued muscle contractions that essentially deplete the myocytes of their ATP stores. Regardless, the causes all lead to this low ATP state in the myocytes. Because of this low ATP state, the sodium-potassium ATPases on the myocytes cannot move sodium across its concentration gradient and pump it out of the cell. It also can't move potassium intracellularly as a result. Because remember, we don't have any ATP to generate this movement. Because we cannot do this, the sodium begins to accumulate inside the myocytes. This accumulation of sodium then activates the sodium-calcium exchanger to move the sodium finally outside of the cell, and as a result, pump calcium into the myocyte. Generally, the myocytes handle this increase in calcium intracellularly is to utilize ATP and the calcium ATPases to then pump this calcium back out of the cell to maintain homeostasis. But remember, we are in this low state of ATP. So these calcium ATPases cannot accommodate this accumulating calcium, and this prolonged high calcium state leads to further muscle contractions, further depleting whatever ATP is left in these myocytes. But also, this increase in calcium will activate calcium-dependent proteases and phospholipases, which will then destroy the structural components of the cell membrane. The loss of membrane integrity leads to a further influx of calcium, which leads to that overload that will disrupt mitochondrial function and integrity and eventually lead to apoptosis. This loss of membrane integrity also allows for the leakage of a number of myocyte components into the circulation to cause further complications. So now that we focused on rhabdomyolysis from the perspective of the muscle tissue and the myocytes, let's move on to the next slide to then discuss those further big picture complications for the patient. So the first component we're going to talk about is creatine kinase, or CK, which is an enzyme that is important in cell types that consume ATP rapidly, like our myocytes. And it's used as a marker for damage in these tissue types that have these high energy demands. And an elevated CK is actually used to diagnose rhabdo and predict downstream consequences of this condition. Next, we'll talk about electrolytes. So when the myocyte contents spill into the bloodstream, there's a significant amount of potassium and phosphate that is released from these cells, and this leads to hyperkalemia and hyperphosphatemia. So the accumulation of phosphate in the blood will rapidly bind any calcium in the circulation, and this will actually lead to hypocalcemia. So both of these electrolyte imbalances, specifically hypocalcemia and hyperkalemia, can lead to arrhythmias. So arrhythmias are one of the important potential complications of rhabdo to be aware of when a patient presents with this condition. Another component that is released are thrombogenic factors, and these can include things like thromboplastin and other prothrombotic substances. And these lead to abnormal and excessive blood clotting throughout the body's blood vessels, leading to compromised blood flow and end organ damage. And later on, this hypercoagulable state rapidly consumes platelets and clotting factors, so that the patient is now at significant risk of bleeding and is no longer able to maintain homeostasis. And this condition is what's called disseminated intravascular coagulopathy, or DIC. The next component up will be the release of organic acids, and this will be things like lactic acid and uric acid. And the release of these leads to a metabolic acidosis. And one of the primary concerns in the case of rhabdo is the lowered pH of the urine from this metabolic acidosis. And this contributes to rhabdo-induced AKI because the acidosis and resulting low pH of the urine increases the likelihood of uric acid precipitating into crystals in the renal tubules, causing obstruction and damage. And this is why fluid resuscitation is so important in rhabdo and why sometimes urinary alkalinization is needed to help with this precipitation issue. As you can see, there are a number of things that are contributing to the rhabdo-induced AKI. But the most concerning is the release of myoglobin from these myocytes. So this release of myoglobin leads to myoglobinuria, which is one of the primary signs of rhabdo, and a lot of patients will report this as tea-colored urine. So myoglobin is the muscle version of hemoglobin, and myoglobin is really only found in the muscle tissue, but it can be found at significant levels in the bloodstream in the case of rhabdo, where all of these contents are spilling out. So myoglobin leads to nephrotoxicity and AKI in 3 different ways. The first is myoglobin has direct toxic effects on the renal tubules and interacts directly with tubular proteins, which leads to the precipitation of casts especially with this acidic urine environment. These casts can lead to tubular obstruction and further kidney damage. The second is myoglobin can induce an inflammatory response. So once it reaches and begins to accumulate in the kidney, it will trigger the release of cytokines. And these cytokines will cause renal vasoconstriction and reduced renal blood flow, leading to further damage. Additionally, patients with rhabdo are usually hypovolemic because fluid will rush from the circulation back into the damaged muscle tissue, further exacerbating this reduced renal blood flow. And lastly, myoglobin is heme and iron containing. And in myoglobinuria, this excess heme and iron can go through redox cycling in the renal tubules to generate reactive oxygen species that trigger further tubular damage. So together, these mechanisms lead to AKI, which should be counteracted with early and aggressive fluid resuscitation to restore renal perfusion and hopefully preserve some urine output. So on to the next slide. So together, this slide summarizes the disease mechanism behind rhabdo and the downstream complications of this condition. So we're spending so much time discussing this because there are a number of pharmacologic agents known to cause rhabdo that you should be aware of. But unfortunately for today, we will only have time to cover 5 different examples, but each is very different with regard to its mechanism of action in this cause of this adverse drug reaction, or ADR. So if we move to the next slide. So let's start with cocaine. So rhabdo is a common complication with a number of illicit drugs, but this is especially true for cocaine. And the way cocaine works is it alters a number of neurotransmitter pathways, but for rhabdo, we're really only going to focus on the neurotransmitter that is norepinephrine. So cocaine inhibits the reuptake of norepinephrine from synapses back into the nerve terminals so that this neurotransmitter signal is never turned off. And this prolonged excess of norepinephrine in the synapses leads to increased activation of its adrenergic receptors, triggering extreme vasoconstriction. This leads to reduced blood flow and ischemia in tissues like our muscle tissue. This lack of blood flow and delivery of oxygen to these cells leads to an inhibition of ATP production by the mitochondria, and this ultimately triggers that chain of events that I mentioned previously that is behind the mechanism of rhabdo's disease. Alcohol is surprisingly similar to cocaine in that they both lead to ischemia, resulting in a lack of this oxygen delivery for mitochondrial ATP production. But the way in which this happens is very different. So in many cases of alcohol-induced rhabdo, the patient presents with short-term alcohol intoxication or binge drinking that has led to alcohol-induced coma or immobilization. And this prolonged immobilization leads to tissue compression and ischemia. And the path to rhabdo from this point on mimics that which we just talked about for cocaine. So let's move on to the next slide to talk about our next agent. And we will now talk about the statin group of agents, which are first line for the treatment of hyperlipidemia and hypercholesterolemia. But these are one of the most well-known agents associated with rhabdo. So statins inhibit cholesterol synthesis. which I won't get into the details because I believe you should already be familiar with the cholesterol synthesis pathway for block 2, and you will touch on this again later on. Just know that statins inhibit the rate-limiting step in cholesterol synthesis, and this is how they ultimately normalize lipid profiles. But remember, cholesterol is an important precursor for a number of molecules needed for normal cellular processes and is an essential component to maintain membrane integrity. So it's thought that statins can lead to rhabdo in a number of ways, but there are two primary ones. The first is this reduced cholesterol compromises the myocyte cellular membrane. And this compromised membrane integrity can alter the function and distribution of these ion channels, and the membrane potential is thrown off. This leads to the dysregulation of a number of cellular processes, including mitochondrial function and ATP production. So the second mechanism we're going to talk about today is the reduced synthesis of ubiquinone. And ubiquinone uses cholesterol as a precursor. So by statins inhibiting the step in cholesterol biosynthesis, we are downstream inhibiting the synthesis of ubiquinone, which is a very important component in the electron transport chain. So little cholesterol means little ubiquinone, and we are in a similar spot as with the rotenone toxicity from the first IQ case, where we can't pass off electrons in electron transport chain, so there's no ATP being made, and there's a backup of electrons, leading to an increase in reactive oxygen species, and eventually leading to mitochondrial damage, and that, again, low ATP state starting this rhabdo cascade. So moving on to our fourth agent we're going to talk about today. Next slide. So the next agent we will talk about is propofol, which is used for the initiation and maintenance of general anesthesia, sedation for mechanically ventilated patients, and procedural sedation. So propofol at very high doses for a prolonged period of time can lead to propofol infusion syndrome, which is often fatal, and one of the primary clinical features is rhabdo. So propofol's exact rhabdo-inducing mechanism is unclear, but it's thought to inhibit the electron transport chain in the mitochondria at complex 2 and 4. And inhibition at these complexes, again, prevents the production of ATP, leading to that low ATP state again, and eventually that rhabdo cascade. So moving on to our very last agent on the next slide, and that is daptomycin. And daptomycin is a lipopeptide antibiotic, and it is used for difficult to treat gram-positive infections like MRSA. And it has a very novel mechanism of action when it comes to being an antibiotic. So daptomycin can actually insert itself in the cell membrane like a usual phospholipid. And then once these are inserted, then the daptomycin molecules can actually aggregate together, eventually forming a channel where ions can travel through down their concentration gradients. And this leads to rapid depolarization of the membrane. And in bacteria, this would lead to bacterial cell death. But unfortunately, at very high doses and relatively shorter dosing intervals, it's thought that daptomycin can similarly insert into the myocyte membranes and lead to this ion influx and efflux down their concentration gradients, leading to rapid depolarization. And again, this rapid depolarization will lead to mitochondrial dysfunction and a lack of ATP production. And also, if there's a lot of calcium influxing into these myocytes, we will get a similar activation of these proteases, further compromise of the cellular membrane, and eventually, again, that rhabdo cascade. So as you can see from these examples, all of these agents initiate this deleterious cascade in unique ways. But the overarching theme is this creation of a low ATP state. So rhabdo is one of those severe adverse drug reactions, or ADRs, that you should be aware of. And if you understand the pharmacology behind some of the agents, like the ones we talked about today, you can use that information to predict what other drugs could be risky, either alone or in combination, in patients that are at risk of this condition. And you can be extra cautious and provide more in-depth counseling before starting agents in a particular patient group that may already have a predisposition for rhabdo. So for instance, say they have a history of alcohol misuse, or poor liver function, or elderly individuals who tend to be dehydrated at baseline, for example. So with the appropriate patient counseling and expectations and a knowledge of the mechanism behind rhabdo, ideally you can stay ahead of this condition that carries significant morbidity and mortality if not prevented or caught early on.